It's my pleasure to welcome you to this wonderful afternoon session on oncology. The moderator and the first speaker will be Dr. Wendy Chen. Dr. Chen is Assistant Professor of Medicine at Harvard Medical School. She's also a physician at the Dana-Farber Cancer Institute and at the Brigham and Women's Hospital. And she is going to talk about Oncology Clinical Pearls. Wendy, you can take it away.
Hi, so thank you so much for the kind introduction, Carolyn. And so let me just give you a brief overview of this afternoon. The first talk is going to be Oncology Pearls for the boards that I'm going to be doing. And this is going to be something that's case-based, and so hopefully get you revved up for the afternoon, since this is a hard time in the afternoon for the people on the East Coast, and for people on the West Coast, still sort of late morning. And then we will also cover a large range of other oncology topics as well, and ones that should really commonly be seen in the clinic. Since none of us know what is actually going to be on the oncology boards, we at least do want to present things that will be of clinical relevance and importance to you. So be prepared for this talk. There are a lot of cases, so be prepared to answer questions. So I do not have any disclosures related to this lecture. And so let's begin with the first case. This is a 60-year-old gentleman who has an 80-pack-year smoking history, and he presents with a 1-week history of facial swelling and cough. On physical examination, you note that he has distended neck veins, prominent chest wall venous distension, and facial edema. His chest CT scan shows bulky right hilar and mediastinal lymphadenopathy. So the first question is, right now, would you A, proceed with mediastinoscopy or bronchoscopy to obtain tissue diagnosis? Would you B, initiate heparin and radiation with plan to biopsy when swelling improves? Choice C, initiate steroids and heparin with plan for biopsy when swelling improves? D, initiate heparin and emergent stent placement and then biopsy once swelling improves? Or E, explain to the patient that this is metastatic cancer and he should consider hospice. And I'll give everyone a chance to answer now. All right, people are still answering, so we're still here, just giving some more people a chance to answer. All right, it's slowing down a little bit now. Oh. Okay, so we'll start going on now. People are still free to answer, but as you can see, the most popular answer was proceed with mediastinoscopy or bronchoscopy, although some people did favor initiating heparin and emergent stent placement, then biopsy once swelling improves. So the answer is actually to proceed with mediastinoscopy or bronchoscopy to obtain tissue diagnosis. And that's because, and I'll discuss this in more detail later on, the second most popular answer about emergent stent placement, he wasn't at the highest level of risk or severity grading, as I'll show in a second. So because he was still at a somewhat lower severity rating, we would actually proceed with mediastinoscopy or bronchoscopy to obtain a tissue diagnosis first. So the point of this oncology pearl is to describe the signs and symptoms and optimal treatment for superior vena cava syndrome. And the pathophysiology is important. It used to be that when I gave this talk, it was really malignancy. And greater than 50% of them are still due to malignancy, which is basically either tumor or mediastinal mass or direct invasion. Lung cancer, both non-small cell and small cell lung cancer, and lymphoma are the most common causes. However, more recently, with intravenous catheters being used much more so than they used to be, thrombosis actually has become quite a common cause of SVC syndrome. So about 20 to 40% of cases in the United States are actually catheter related and not directly related to the malignancy. In terms of physical examination, some of the findings may include facial edema and plethora, jugular venous distension, and venous distension of superficial veins on the chest. In terms of symptoms, it was shortness of breath, cough, and hoarseness are the most typical ones. And here is the grading of SVC syndrome. And along with it, as you can see, is the incidence. With the most common, what this gentleman presented with, which would be moderate or with mild impairment in terms of cough, dysphagia, or movement. I did not provide additional details, but at least in the brief case summary, there was no indication that this would be considered severe. And so therefore, it would not need immediate stent placement. And as you can see, being fatal, it's actually less than 1%. So even though it's obviously quite terrifying to see someone who presented with significant cerebral or laryngeal edema, it actually is very, very uncommon to cause death. And that's because in general, it's something that happens more gradually over time. And so in terms of the management, imaging, the chest CT is generally preferred, with the one exception is if there's a very, very high suspicion for catheter-related thrombosis, you actually can go directly to an ultrasound. But really, the tissue diagnosis is critical for treatment decisions. And that's because the treatment options are highly dependent upon tumor histology. And as I show here, chemo-insensitive cancers, so ones like non-small cell carcinoma, those actually upfront radiation, and we would potentially consider stent placement sooner rather than later, whereas someone with chemosensitive tumors, such as small cell lung cancer or lymphoma, those really would be upfront chemotherapy because they respond very well. So this is another reason is that we're assuming this person had lung cancer because of the pack year smoking history, but we actually don't know, is it small cell or non-small cell? And we would think of those two very differently in terms of the likelihood of stent placement. And the indications for stent placement are either life-threatening symptoms such as airway obstruction, severe laryngeal edema, or coma from cerebral edema. The diagnosis is not established and you need that extra time, or if someone has refractory or relapsed disease such that we're worried that upfront treatment may not work that well. And as I said before, even though, yes, you want to do things in a timely fashion, it is rarely fatal. So now we're going to continue with case number 1, but there's going to be a different twist. So he has been diagnosed with lung cancer, and he's been treated with pembrolizumab for the past 3 months. And now he presents with 2 days of dry, non-productive cough. He denies fever, chills, or dyspnea. Let's think about this and ignore COVID right now. I should say this up front. This person does not have COVID. That is not one of the answers to the question. So again, 2-day history of dry, non-productive cough, denies fever, chills, or dyspnea. Physical examination, he appears well, and on lungs, they're clear to auscultation. Room air saturation is 96% at rest, but with ambulation, he actually desaturates to 90%. So now, again, I would ask, what would you do next? Would you A, do a bronchoscopy, B, do viral cultures and give empiric moxifloxacin, C, recommend inhaled steroids and a bronchodilator, D, order a CT scan, Or E, start prednisone at 1 milligrams per kilogram, then taper. And as I said before, this person does not have COVID. That is not in the differential right now. And I'll give everyone a chance to answer now. Great, people are still answering, which is great. Okay, now it's starting to slow down again. So as you can see, the most popular answer here was CT scan, with all the other answers much less popular. And that actually is the correct answer, is a CT scan. And so what I'd like to talk about here is actually immunotherapy toxicities, which, even though you're not going to be giving immunotherapy, well, hopefully not, you will most definitely be taking care of patients both in the outpatient and the inpatient setting who may have immunotherapy toxicities. And so when we talk about immunotherapy, even though, yes, that means things that affect the immune system, we're actually talking about a fairly specific class of medications, what are called checkpoint inhibitors, so ones that are trying to basically take the brakes off of the immune system. And there's three commonly used classes of drugs that when we refer to immunotherapy and checkpoint inhibitors, it's inhibitors of PD-1, inhibitors of PD-L1, and inhibitors of CTLA-4, and these are the names of the drugs. And these drugs are widely used for many different types of both solid tumor and hematologic malignancies. So they're very, very widely used in cancer right now. And there's a really wide range of side effects that varies a little bit with what class of drug it is, for instance, PD-1 versus PD-L1, but also can be very, very different from individual to individual, and it can be difficult to predict. Interestingly, it is not dose dependent. So it can happen at the beginning, it can happen later on. It's not necessarily a cumulative effect the way that some of the side effects of standard chemotherapy are. And the timing is also highly variable. It can occur quickly, but it can occur months after exposure. I've had some patients, they've actually already had stopped their immunotherapy, and then they got side effects after they had already several months after stopping immunotherapy. And it can be fatal. And so that is why, as oncologists, we're very, very mindful of immunotherapy toxicities, because they can be rapidly fatal. So the most common one that we think about that ends up landing people in the hospital or needing treatment are gastrointestinal ones. And that most commonly is colitis. And it happens anywhere between 8 to 27% of the time. And the important thing to remember is diarrhea is really the most common gastrointestinal symptom when it comes to immunotoxicity colitis. Nausea and vomiting actually is not that common. It's really diarrhea and sometimes abdominal pain as well. Hepatitis is also something that we see. This is more of a laboratory abnormality than anything else. AST and ALT most notably. And as you can see, can happen in up to a third of patients. Pancreatitis can happen, although that is quite rare. And then pulmonary, I would say, is the other major one that we worry about in terms of ones that are potentially fatal, and also ones that will land people in the hospital. And so it classically presents as a pneumonitis, often as these ground glass opacities. But again, it can be quite variable, and it can occasionally mimic a pneumonia or something. But again, most commonly ground glass opacities. The reason it is important to recognize the potential that someone has a pneumonitis due to immunotherapy is the fact that it can really rapidly worsen if you don't begin treatment immediately. And I'll talk about treatment in a second. The other toxicities to think about, but these are less likely to land people in the hospital, would be endocrine ones, most commonly both hypothyroidism and hyperthyroidism, primary adrenal insufficiency, hypophysitis, and diabetes. And these actually can all be symptomatic as well, and not just laboratory abnormalities. Arthritis and myositis is quite common. Dermatologic, a large range of rashes that people can have. And then many other rare things that I'm not really going to go into detail right now. But the ones that you'll see most commonly when you're taking care of patients are the gastrointestinal and pulmonary ones. And so most importantly, management. So it is extremely steroid responsive. So this is why one of the choices in the multiple choice question had been to start the prednisone taper, prednisone at 1 milligram per kilogram, and then taper. Because if you do have a very high suspicion for immunotoxicity, the sooner you start steroids, the better. And depending upon the situation, immunotherapy can sometimes be restarted even after someone suffers an immunotoxicity side effect. And it really can worsen rapidly. So you do want to ensure close follow-up. And this I really cannot speak most highly about, which is involve your specialists early, especially again for the gastrointestinal and the pulmonary ones, which really can escalate very quickly. It is so important to call your specialists earlier rather than later. So now we're going to move on to case number 2. This is a 64-year-old gentleman with metastatic prostate cancer to the bone, with metastases to the ribs, pelvis, and multiple vertebrae. He's currently on docetaxel chemotherapy. He calls you complaining of 1 to 2 weeks of increasing mid-back pain. He does not have any weakness, radicular pain, bowel or bladder difficulties, and his neurologic exam is normal. So then would you, A, order a bone scan and CT scan to look for disease progression? B, prescribe NSAIDs and oxycodone as needed for pain? C, obtain an MRI of the spine? Or D, recommend radiation to the spine? And I'll give you a chance to answer. Okay, so the number of people that are answering are slowing down now. So the most common answer was obtain an MRI of the spine, and the second one was order a bone scan and CT scan to look for disease progression. And the correct answer is to obtain an MRI of the spine. And so this is to describe the signs and symptoms and optimal management of spinal cord compression. Also, spinal cord compression, you do have to initiate treatment early to prevent neurologic defects. And this is a common mistake, is that once neurologic deficits have already occurred, it's often irreversible. So you don't want to wait and say, I'm not sure of the diagnosis, they don't have a weakness, they don't have sensory changes. You actually don't want to wait that long. It's generally from epidural compression from vertebral body metastases. The most common tumors are lung, breast, prostate, myeloma, lymphoma, and renal cell. The thoracic spine, interestingly, is the most common location about 60% of the time. And that's because the thoracic spine is actually very well vascularized. So is an area where you can definitely get tumor. And then the other thing is it's an area where the spinal cord is narrower. So whenever someone tells me about thoracic mid-back pain, that always, and they have cancer, that always raises a red flag in my mind, because the mid-back is not that common an area for arthritis and a lot of degenerative changes. That's common in the lower back. So always think cord compression in anyone with bone metastases and mid-back pain. Here's both a picture in terms of a diagram and then also an MRI, as you can see, examples of tumor that's beginning in the vertebra and then growing into the cord. And so, as I said before, new or worsening back pain with known vertebral mets always need to be evaluated. The pain can be radicular, but it isn't always. Weakness, the motor deficits will come before sensory, but again, you don't want to necessarily wait for motor deficits to happen. And bowel and bladder symptoms really occur quite late. And the neural exam may be normal. So the key is early diagnosis. And MRI is the imaging of choice, which is why it was that question, that answer, rather than a CT scan and bone scan to look for progression. Because sometimes the only area of progression can be seen in the spine. So the first thing is corticosteroids to decrease edema. And only short-term benefit. So the only time you should not use steroids is if the diagnosis is unknown. And typically it's a 10 milligram IV load and then 4 milligrams orally every 6 hours. Radiation is the first line treatment for most. And the only exception is upfront surgery is reserved for if you don't know the diagnosis, you do need tissue first. Progression during or after radiation, because you can't rearranged an area in a very short period of time. Any evidence for spinal instability. And interestingly, there was one randomized trial that did show improved function with immediate surgery for less radiosensitive tumors with a single area of compression. But this randomized trial really expected people to go to the OR much more quickly than usually would be able to happen in most practices. So now we're moving on to case number 3. A 62-year-old gentleman presents to the ER with a temperature of 101.4, malaise and cough 15 days after receiving chemotherapy for refractory lymphoma. His physical examination is unrevealing for a source. His white blood cell count is 640 with 45% polys. His chest X-ray is negative and cultures are obtained. And again, let's assume that he's COVID negative. So case number 3, in terms of what would you admit the patient and start cefepime, admit the patient and start cefepime and GCSF, admit the patient and observe without starting anything, discharge patient home on oral quinolones and GCSF, discharge patient home on oral quinolones, and I'll give you a chance to answer. Okay, so interestingly, both A and B were almost split 50-50. Admit patient and start cefepime, admit patient, start cefepime, and GCSF. Now I'll give you the answer. And it's admit patient and start cefepime, but not include GCSF, and I'll explain why. And so now we're going to talk about the optimal management of febrile neutropenia. So this is the definition of a fever. And then in terms of neutropenia, it's when the absolute neutrophil count is less than 500, or you have a predicted nadir of less than 500 in the next 48 hours. So the reason why we worry about this is the risk for occult infection and mortality increases as the ANC falls below 1,000. The greatest risk is with an ANC less than 500. the mortality rate for solid tumors is less than heme malignancies. This person had lymphoma. Growth factors, as many people had chosen, they actually only modestly decrease the duration of neutropenia and hospitalizations. And when I say modestly, I mean very modest. There is no impact on mortality, and therefore there is no significant benefit to the empiric use of G-CSF in uncomplicated fever neutropenia. Obviously, if there's someone with a prolonged course, other complications, it's different, but this gentleman would be considered uncomplicated fever neutropenia. So the risk factors for developing fever neutropenia are a rapid decline in the ANC, prolonged duration of neutropenia, leukemic induction, uncontrolled cancers, or hematologic cancers. The typical infectious sources of fever and neutropenia are catheters, skin, the respiratory tract, sinuses, or GI tract. However, the source is identified in less than 30% of the cases, and in the time when it is identified, it's often endogenous flora. So 80% of the cases that it's identified in, it's endogenous flora. The most likely organisms are gram-positive infections, about 50 to 60% of the identified ones. But gram-negative rods, which are the ones more likely to cause death, and most commonly Enterobacter and Pseudomonas. And so the routine evaluable fever and neutropenia are the history, physical examination, routine laboratory tests, routine cultures, and a chest x-ray. You do not need to do a chest abdominal pelvic CAT scan on everyone with fever and neutropenia, only if warranted by symptoms. And the empiric antibiotics should be something that's broad spectrum with gram-positive and gram-negative coverage, especially Pseudomonas. So a third-generation cephalosporin, such as cefepime, would be very common. It depends upon the local hospital bacteriology, and these are alternatives. Specifically, if someone has a beta-lactam allergy, it could be aztreonam and vanco, or Cipro and clindamycin. But one should realize that there's only a less than 1% chance of cross-reactivity between a third-generation cephalosporin and someone who has a true penicillin or allergy to a first-generation cephalosporin. Vancomycin for fever and neutropenia does not improve morbidity or mortality when it's used empirically, and it encourages the development of vancomycin-resistant enterococcus. Therefore, we only use it in situations in which there's a very high suspicion for a line and skin infection, MRSA, widespread mucositis, or obviously a severe penicillin allergy. Low-risk fever and neutropenia, so who you could treat as an outpatient, would be if someone has an anticipated duration of neutropenia less than 7 days, a solid tumor, is clinically stable, and no major comorbidities, adequate oral intake, their malignancy responding to correct treatment, and you would need to observe them for a few hours before discharge. So now case number 4. This is also the person with a mantle cell lymphoma admitted day 9 after chemotherapy with fever and neutropenia. Her fever resolved very promptly with institution of empiric antibiotics. 1 day later, her blood cultures grew E. coli sensitive to amoxicillin. Her ANC is currently 246. So would you A, stop IV antibiotics and discharge her on oral amoxicillin? B, continue IV antibiotics until her ANC is greater than 500. C, obtain an echocardiogram to evaluate for endocarditis. Or D, stop IV antibiotics and start amoxicillin, but continue to observe her for 48 hours in the hospital, and I'll give you a chance to answer. Okay, so it looks like the most common choice is continue IV antibiotics until the ANC is greater than 500, and then D is the second most common choice about starting amoxicillin and continuing observation. And so it's actually continue IV antibiotics until the ANC is greater than 500. And so when can antibiotics be stopped or changed? And it really is only when both fever and neutropenia have resolved. For this person, only the fever has resolved, but the neutropenia has not resolved. And so for this person, once her ANC is greater than 500, then she could complete a course of antibiotics, and then it could be oral antibiotics. If the ANC is greater than 500 and afebrile, and there is no source isolated, you can discontinue antibiotics. There is no need to just give someone empiric antibiotics if their ANC is greater than 500 and no source is isolated. So case number 5. This is a 57-year-old woman with metastatic lung cancer who is brought to the emergency room with confusion. Her serum calcium is 17 and her creatinine is 1.5. 4 liters of normal saline and IV furosemide are administered. What is the next most appropriate therapeutic intervention that should be taken first? And the choices are A, administer another 2 liters of normal saline, IV, and furosemide. B, denosumab 120 milligrams IV. C, zolendronate 4 milligrams IV. And D, chemotherapy for lung cancer. And I'll give you a chance to answer. Okay, so the most common answer was zolendronate 4 milligrams IV with the denosumab and another 2 liters of normal saline, less common answers. So the correct answer is zolendronate 4 milligrams IV, and that's because denosumab is actually given sub-Q and not IV. And yes, you could give another 2 liters normal saline, but at this point you've already given her some normal saline and furosemide, so you really would want to pursue something else. And so we're going to talk about the optimal management of hypercalcemia. So this can occur in both solid and hematologic cancers, and the most common ones are the ones that involve the bones. So that would be breast, lung, and myeloma. The incidence actually has been sharply decreasing among metastatic patients. And that's because nowadays bisphosphonates are actually used routinely to prevent such complications in patients with a wide variety of bone metastases. So this is something that we actually see much less commonly than we used to. An urgent treatment for hypercalcemia is obviously very important for palliation, but in terms of long-term prevention of recurrent hypercalcemia, you actually have to treat the cancer. If you do not treat the underlying cancer, the hypercalcemia will keep on coming back despite the use of bisphosphonates or denosumab. And so the most common cause of hypercalcemia in malignancy is actually tumor secreting the PTH-related protein. The other ones that are listed are actually much less rare. The local osteolytic hypercalcemia is mainly in breast, myeloma, and lymphoma. And the last two are also both extremely rare causes of hypercalcemia. And the management is what we did first, which is IV normal saline volume repletion. That's actually a very fast way to bring the calcium lower. And then you also want to inhibit the osteoclastic activity, either with a bisphosphonate, or the alternative would be denosumab, which is an antibody to rank ligand. Calcitonin actually has very rapid onset, but much less potent and with a very short duration of action, so we don't really use it that regularly. Dialysis is only used in very rare circumstances. So that's, for instance, if someone has congestive heart failure and it does not allow aggressive volume repletion, or if someone has oliguric renal failure. And so when you're choosing what to use to treat the hypercalcemia, should you use bisphosphonates or should you use denosumab? So oral bisphosphonates are less potent and they are not used for treatment for hypercalcemia, nor do they prevent people from getting hypercalcemic. So you may have people on alendronate, abandronate, they're still going to get hypercalcemia anyway if their cancer is not under good control. And so how do you make the choice of zoledronate versus denosumab? They're actually both associated with osteonecrosis of the jaw. Although you hear about it more with zoledronate, it actually does occur with denosumab as well. In head-to-head trials, the results are somewhat mixed. Some of them showed that they were equivalent, and some of them showed that denosumab was slightly superior. The only trouble with denosumab is it can be associated with refractory hypocalcemia, so overcorrecting the other way. One advantage, however, is it can be used in severe renal impairment in contrast to zoledronate, but it is considerably more expensive. So because of the expense issues, I would say zoledronate is often used more widely for hypercalcemia. So this is one of these things in which we're going to just have a little bit of thinking about epidemiology, which is which of the following pairs a proven cancer prevention action and the cancer it prevents. So number one, A, tobacco cessation and bladder cancer, C, hepatitis C vaccine and hepatocellular carcinoma, C, decreasing soy consumption and breast cancer, and D, HPV and uterine cancer. So again, which of the following pairs a proven cancer prevention action and the cancer it prevents? I'll give you a chance to answer. So the most common answer is tobacco cessation and bladder cancer, with the hepatitis C vaccine and HPV answers being the second two most common ones. And so that is the correct answer. And let me show you why. So which cancers are associated with tobacco? It's a long list: head and neck, pancreas, bladder, lung, esophageal, and kidney. Smoking is a very strong risk factor for bladder cancer. Ionizing radiation causes thyroid, Hodgkin's, breast cancer, lung cancer, and leukemia. In terms of infectious causes, hepatitis B and C are both associated with hepatocellular carcinoma. However, there is no hepatitis C vaccine right now. We do have a hepatitis B vaccine, but not a hepatitis C vaccine. And the other important things to remember are Epstein-Barr virus with post-transplant lymphoma and nasopharyngeal cancers, and HPV. It is not associated with uterine cancer. It's associated with cervical and anal cancer. So these are just things to memorize, and they are important to know. And now we're going to move to the final case. A 38-year-old gentleman presents with chest pain and shortness of breath. A chest x-ray shows a mediastinal mass suggestive of cancer. Which of the following blood tests would be most helpful to identify the primary site? Would you check A, a PSA, B, a CEA, C, a CA19-9, or D, HCG? And I'll give you a chance to answer. Okay, so the most common choice was HCG, with CEA being the second most common one. And the correct answer is HCG. So what I'd like to talk about is how to evaluate a cancer of unknown primary. And the first thing that you want to do is definitely a chest abdominal pelvic CT scan with contrast. It's unclear if a PET CT is superior or not. Focused tumor markers. They can often be non-specifically elevated, but a man with adenocarcinoma in bone mets, you do a PSA. A man with a mediastinal midline carcinoma like this person had, it would be an HCG and alpha fetoprotein for a germ cell tumor. And then immunohistochemistry or gene expression profiling could also be helpful to determine the primary site. In general, adenocarcinoma is the most common, about 70% of the time. Poorly differentiated cancers are 25% of the time, and squamous cell carcinomas are about 5% of the time, with cervical and head and neck primary, or inguinal, genital, or anorectal primary. Neuroendocrine tumors are only 1% of the time. And so what is the key? It's really to find treatable non-metastatic cancers. That's important. So for instance, a woman with axillary lymph nodes, that is generally going to be a node-positive breast cancer and can be treated potentially with curative intent. Neck nodes with a squamous cell carcinoma, in terms of the histology, that's actually a locally advanced head and neck cancer, and again, can be treated with curative intent. A young man with a mediastinal or retroperitoneal lymphadenopathy, like I just described, is a germ cell tumor. And then finally, a woman who presents with peritoneal disease, that is a stage 3 ovarian cancer. So these are 4 clinical scenarios that's important to recognize immediately when you think of cancer of unknown primaries. And then finally, when you think of cancer of unknown primaries, you really want to focus on finding treatable metastatic cancers. So metastatic cancers that if you treat them, they can generally have a good many years of survival and good quality of life. And this list actually has been changing over time and increasing over time as we've gotten more and better cancer chemotherapies and treatments. So breast, ovarian, prostate, germ cell, lymphoma, melanoma, head and neck, colorectal cancers. These are all cancers that we do have treatments that could improve quality of life, improve survival, and ones that would be very, very worthwhile identifying so that you can give them the correct targeted treatment. So I wanted to thank you very much for your attention to this.